we've long had an interest in what the outcome was from any given exacerbation of multiple sclerosis, which is to say some attacks are mild, some attacks are severe, but more importantly, do the individuals recover fully or partially from attacks? And what we've shown in the past, and others as well, that approximately 50% of attacks leave some sort of residual damage. Hence the importance of trying to lessen the number of attacks, but also the severity of attacks. In this particular poster, looking at the AFFIRM study, we compared the recovery from exacerbation in those individuals who received natalizumab versus those who received placebo. And what we showed was that the exacerbations were less severe in individuals on natalizumab, and that the recovery was better when you're on natalizumab as opposed to placebo, meaning that not only do disease-modifying therapies like natalizumab cut down on the number of exacerbations, but they cut down on the severity of the exacerbation and improve the chances of having a better recovery from any given exacerbation. One of the interesting topics of conversation at this year's meeting was the relative merits of an escalation therapy approach versus an induction therapy approach. In escalation, you would start a disease-modifying agent that tended to be safe, maybe not the strongest, but adequate to treat the patient and watch and make sure they respond. If they didn't respond or are having more attacks, then you go to the next more aggressive therapy. The induction approach advises hitting people hard up front with an aggressive therapy and then over time switching to something that might be a little more safe. The concept hinges on being able to determine early on who's going to do badly and who's going to run a milder course. And my own personal belief is that we're not there yet, being able to predict who those individuals are. In terms of the future, the big hope for the future right now is to develop disease-modifying therapies that can affect progressive disease.